Welcome to Urogynecology and Pelvic Healthcare. In last, we have seen the type of incontinence, what are the various types of incontinence, how they are together also, and how they differ from each other, and what is importance in the relevance and management approach. So finally, when we arrive at the conclusion that this is the type of incontinence, how to exactly assess the patient or how to proceed further, this we are going to see in today's session. Okay. So approach to the patient. Always Urogyne is always about a good history and a good history. So review of the symptoms, how often? Once in a while. The patient may say the SUI episodes in 1 in 3 months, 1 in 6 months, urgency she may have daily. So how often she is having, how much? It's very important to know how much the quantity. She may say underwetting of just the undergarments. The patient may say till the knee the urine dribbles, or on the floor whenever she goes, that amount, huge amount it comes. So even the duration frequency may be less of that symptom, but whenever occur it may be so severe. So that is important to know which factors aggravate the symptoms or improve the symptoms. There is any usage of pad. Now here I will show you the example. There was of a patient which she had the incontinence. She came to us with the complaint of urinary incontinence. So we started on her the treatment, and when she reviewed after 4 weeks to us. So previously she used to she was having incontinence since 1 to 2 years. She used to use the pad history was very occasionally. Whenever she used to go outside on the long travels, she used to have the use of pads. Now when she came after 4 weeks, she was very happy that she is very good. There is no urgency. She was quite satisfied. Okay. Then when we did the examination, we saw that she was using pad, and to our shocking that she was not using previously the pad. Now she has started using the pad. So it was not matching. So we asked her what was the reason for using the pad, whether it's so severe, because the patient complained now and she does not wet. Now what happened is that she got very better. Initially it was daily wetting of the clothes, a very small amount. Now with the over a period of time in the 4 weeks, she improved very significantly. There was no leakage. Now even a small drop, she was bothered more with the urgency, as she said previously. Now the urgency is solved, but now she was having SUI because urgency got great. Now she was having SUI, and as her quality of life, she was feeling better. She even means for that small drop also of SUI, she was fearful that it will leak. So she started wearing the pad regularly. So isn't it contradictory? She initially, when she was having very severe daily wetting of the clothes, that time also she did not use the pad. But now she has gained a sense of improvement. She was happy. She is not leaking. She can go because of small drop. Now her SUI predominated. She previously she is not able to hold only even the 100, 110 was the pre-void. That much only she was able to hold. Now this got better. So you need to re-evaluate whenever the patient come for follow-up. It's not like that initially it was urgency, abhi bhi urgency rahega, or the same symptoms. So you always need to ask again what was the scenario of the patient. So usage of pad, even the patient does not say in all urogyne patient, in each and every step history is very important. The effect of symptoms on the quality of life, when the patient gets start improving, even the some patients are okay with small leakage. Okay, पहले बहुत ज़्यादा था, now with just small drops they're okay. Some patients are like, okay, I'm getting this much, so I even don't want even this amount. So what is the patient expectation, patient goal from your treatment? That is also very important. Storage symptom, fun, frequency, nocturia, and the urgency part, this is important to see. Voiding symptom, whether the patient complains of voiding difficulty or no. Irrespective of the patient complaint of any storage symptom, you need to ask the voiding irrespective of the patient of any voiding complaint, you have to evaluate for voiding symptom, because the voiding problems or the voiding pathologies which lead to voiding symptom, they may present as the frequency urgency. Even in the case of bladder outlet obstruction, the patient may have repeat frequency because she is not able to empty the bladder. She may have leakage because of chronic retention of urine. Basically she have the problem of voiding. So again you need to evaluate in that way. Okay. So hesitancy, slow stream, intermittency, straining to void, position dependent micturition, this we have seen in the last lecture also. Dysuria, past medical history, diabetes mellitus, pulmonary any chronic COPD, asthma, neurological vascular insufficiency, drug history, benzodiazepine, anticholinergic, antipsychotic, alpha blockers. Past surgical and treatment for incontinence. Patient may have taken Sometimes patient does not feel that their history is important, they don't say, but many of the patient, some or they have taken anticholinergic drugs in the past. So, important points in the history, what you have patient, if there's a start of urination, it usually indicates urethral pathology. If it's at the end of urination, it usually indicates bladder. It's not hard and fast, it usually indicates symptoms of overactive bladder. You need to see whether it's there in history. Fever, flank pain, systemic, this usually signifies that there has been some damage or there is some problem with upper urinary tract symptom. Vaginal discharge, the patient may have no urinary pathology or urinary complaints because of chronic vaginal discharge. She is having urinary incontinence. Okay, so the transient one also may lead to the chronic if not treated. Menstrual history, some patient may typical is in cases of bladder endometriosis. Patient may have relation with bladder menstrual cycle. When there is a menstrual cycle, then there is a pain in bladder, or hematuria may be seen in urine. So you need to correlate the urinary symptoms with menstrual history also. Recent sexual activity and the types of contraception she is using, that is also something important. So initial assessment, whenever patient comes, you take the detailed history, onset, frequency, duration, degree of bother, how much she is bother, which symptom bothers the most, what's the impact on quality of life, whether she has stopped going out, associated symptoms, she's having prolapse, constipation, chronic cough, medication history, examination, general, overall general status, you see height, weight, gait assessment. Systemic examination include pelvic examination to look for prolapse, atrophy, levator tone, anal sphincter tone, to see whether she will be able to do the Kegel exercise. If you teach her pelvic floor, whether she is able to do it. Neurological examination, perianal reflex is something very important. Her mental status, or there is any caregiver with her. So to understand how to give her, if you train her for bladder retraining or the time voiding, schedule voiding, prompt voiding, she is able to understand it. Examination of the patient in full bladder, comfortably full bladder, for demonstration of SUI. So this is very important while you do the initial assessment. So abdominal examination, you see, is there any tuber mass which puts the pressure on the bladder? Because if it's there, if you remove that mass, then the bladder symptoms will go. Hernia, the many patients, not many, there are some patients which have prolapse also and hernia. Basically, there is a defect in the connective tissue, fascia. So patient may have both. So if you're undergoing any surgery for prolapse, you more consciously or more definitely you look for whether there is any umbilical hernia or any previous incisional hernia, so you repair it in the same setting. Okay, so pelvic examination, you see the excoriation. There may be patient may say no, she is comfortable, she is not having much of the urinary problem, what they consider it as routine. But when you see the vulval examination, perineal examination, the skin is excoriated, means she is having dermatitis, prolapse, atrophy. There are many asymptomatic prolapse. Stage 3 also, the patient may be obese patient, they should not be aware of it that there is something sensation of prolapse. So when especially when there is only single compartment prolapse, cystocele and rectocele, the patient may literally be totally asymptomatic and patient may have stage 3 prolapse. So it's not unusual to find. So but if the symptoms are correlating because of prolapse, so the prolapse will not always manifest as prolapse, something coming out. Patient may have some urinary or bowel complaint, and the patient may manifest with that instead of being manifested as prolapse. Atrophy of the tissue, you always look and treat for atrophy if it's present, even if there is no symptom of atrophic vagina. Tone of pelvic floor assessment is very important if you're planning for conservative management, even for the post operative rehabilitation of pelvic floor tone. You should know pre-operatively demonstration of any leak, cuff stress with the comfortably full bladder. But even if you see in the empty bladder, many times when we do with the gynec examination, we say ask the patient to empty, and when we examine, then the patient feel comfortable and says, oh, I have the urine problem. And if you ask at that time to tell the patient to cough, and you see there is a leakage, that is nothing but the empty supine stress, and it's indication of more severe form of SUI. So Boni step nowadays is not done, it's the modified Boni. We have one previous video which we have described the modified Boni test. Q-tip test is also painful, not done. Nowadays what we do is the vaginal swab test. Just instead of below the urethra, you put the swab on the same angle as a Q-tip. Q-tip is inside the urethra, and the vaginal swab test is just below the urethra, and you see for the urethral mobility, whether it's hypermobile or it's fixed. Pediatric Foley test is also not done. It is usually for the ISD demonstration. Neurological examination same as we previous completely. Urine analysis you see for the bacteriuria, persistent bacteria, you see for sterile pyuria, hematuria, glucoseuria, post-void residual volume. We'll have a one detailed lecture on this post-void volume, why, when and how to do it, what is significance, only 50 is normal, 60 is normal or 80. Basically, just to give a brief about it, post-void residual volume will depend upon the pre-void volume. That will decide whether it's normal or it's abnormal. Okay, so initial test when comes bladder diary, very important, demonstration, therapeutic also. The patient will know the awareness when and how much she is voiding. Now important is to include both the active and the leisure days. What happens when the patient is usually working? At that time she have the problem, but when you ask her to do the bladder diary, she is on off home and she is doing the bladder diary, and the symptom or the history will not, it will not match your history what the patient is giving, what the bladder diary is showing. So you should involve both the active and leisure. Now for working it may be somewhat difficult. For working women it may be somewhat difficult, but if in that case you're not able, you can have just a frequency volume chart if comfortable. But yes, at least 3 days you can have at least for 1 day, but it's most important in which scenario she is having the difficulty of urination. In that same environment she do the bladder diary. If she is a working, she should do in the same routine, she should fill the bladder diary. Urine routine microscopy, yes, you should see, look for blood, sugar, nitrites, glucosides. Urine culture, if urinary feature tract infection features are present, then only, don't do routinely urine culture. PVR, as I previously also said in the last lecture, you can do it by bladder scan or the catheterization, whichever is feasible and acceptable to the patient. Feasible, if you have the service of bladder scan volume, yes, you can do it. Acceptable, something intervention, painful, the patient is already a cane of suppose chronic pelvic pain, or she's having some bladder pain, dysuria, burning micturition, and that you're doing, the patient may not be comfortable with. But suppose if you want to take repeated recurrent urinary tract infection and you want to take the catheterized sample of urine, so yes, you have to do it. If you want to calibrate the urethra and even see the PVR, so putting a catheterization is better. Which is superior, inferior, both has its own advantage and disadvantage. But to summarize for the practical tip, what I would like to say is that whenever, if there is a previous ultrasound has been done of the patient, at least once, means you should have both the value of PVR, one is by ultrasound and one you have done by yourself. Ultrasound will rule out bladder diverticulum and other things which you may not see by catheterization, and ultrasound detects the bladder volume higher, it's more what you see. So one, in a single patient you should have both the value. If her complete ultrasound once it is done, then next time always you can have done by PVR. If you need to do it repeatedly, in many patients in follow-up you do it repeatedly PVR, so in that you can have it. And the second thing is that if then like one, you get the ultrasound complete and you have complete ultrasound is done, KUB and everything, and you have the all the pathologies ruled out and you have the PVR. And once you have a single pass catheter and you have checked for the PVR. Now in any case when you have the repeat follow-up, you can, if you're having bladder scan facility, you can obviously go with bladder scan. So which is feasible and whichever is active. Now this is the sample of the bladder diary, which helps to clarify the diagnosis where the history and diagnosis are inconclusive. It should be done routinely, but many patients does not do it or it's not possible. But specifically when your patient, whatever she is telling and your assessment is not matching, or the history and the clinical everything assessment is not matching, then definitely bladder diary is something diagnostic, it's something you have to do, and that only when you explain the patient are willing to do it when there is no conclusion, because it's a very much nice method to know what is the problem with it. Now in this you can see the urinary time is there, then the amount, at what time how much she is passing, accident urine, that what time she leaked it, activity whatever she is doing, whether it was urgency or it was a stress urinary incontinence. And at last column we have specifically taken this chart to mention the fluid intake. If the last column is deleted, the fluid intake type, then it will give you the frequency volume chart. So minimum, if this patient is cumbersome, bladder diary is the best, at least for 3 days, if not at least for 2 days. If not, bladder intake and output is not there, at least you do the output record. And intake, you just roughly ask 24 hours how much she has taken, not by time wise. So this is the minimum a patient can do, and it will help very much in the diagnosis part. So when is the indication of advanced invasive urodynamic test? When no definitive diagnosis is made with initial assessment, including the bladder diary. Before proceeding for urodynamic study, it's better to have a bladder diary in hand, because urodynamic study is something, investigation is not like an ultrasound. You just order and see what is the finding. You should know the questions which you want to get the answer of it. So urgency predominant mixed urinary incontinence, any suspected neurological problems, UDS is must. Anterior apical prolapse, yes. Failure of previous incontinence surgery, it's a must. Prior pelvic organ prolapse surgery, yes, you should do it. Sometimes suggestive voiding dysfunction, yes, it will help you in the clear idea will get what is the cause, at what level is the obstruction, or what is the cause, underactivity or the outlet obstruction. So basically clear-cut indication for urodynamics where there is urge predominant mixed urinary incontinence, or urinary incontinence in which the type is not clear. As we discussed in our previous lecture, that is nothing but the insensible urinary incontinence. Even when the patient is confused, you're not able to which type of incontinence, and you won't plan any intervention is planned, definitely you can go for UDS. Symptoms suggestive of voiding dysfunction, yes. Anterior apical prolapse, history of previous surgery for SUI is something very much must. Now, having said this all, do not perform multi-channel filling and voiding cystometry before primary surgery if SUI or stress predominant mixed incontinence is diagnosed based on a detailed clinical history and demonstrated SUI at examination. Because in many cases, even the urodynamics, urodynamics is nothing for the diagnosis of SUI. Suppose if you have the stress urinary, you're planning for surgery. So in that cases, you don't do SUI. Basically, urodynamics will not say it's overactive bladder or a stress urinary. Urodynamics, you're going to see the detrusor Qmax pressure, P detrusor at Qmax, P detrusor opening pressure. Is there any voiding difficulty? Patient is able to relax. What is the compliance? Is there any threat to upper tract? Basically, other scenes are. You're not looking for urodynamics whether it's urge or SUI. You're looking for is the operative pre and post, the baseline is good, compliance, activity, detrusor activity maybe not very much is there, which is the predominant, how she's able to void, she's completely able to relax the pelvic floor. So this all you need to, there is abdominal straining, Valsalva, that is all you're going to see for the in the urodynamics. So pre-operative urodynamics not recommended in patients with uncompleted SUI who desire sling surgery. So there are some studies like 12% of women in sister study, this was a study with a stress incontinence surgical treatment efficacy trial was done, and Thomas had absence of urodynamic SUI. So as I said, SUI will not show you if SUI urodynamics if SUI does not appear, so it doesn't mean that patient is not having. You have to believe the patient, and the clinical symptoms is more important as far as the symptoms of incontinence is considered. Yes, urodynamic will help you when she's having insensible or she's not aware what are the symptoms or there is confusion diagnosis. But if there is no incontinence in urodynamic study, it does not mean that patient is not having incontinence. Okay. So clinical SUI and pelvic, clinically history, that's why always history is very important. If there is clinical SUI is there, then there is no need for urodynamic study. Decision to treat is based on the patient's reported bother from incontinence. Okay, how much she is bother on that, not on the UDS. Which intervention is needed to do, that you can decide with urodynamic, conservative, or which type of sling and what is there, or should go or not, or what will be the outcome to counsel her, whether she will have recurrence of urgency, that you can see with urodynamic studies. Okay. So risk factor, just to summarize short, pregnancy, vaginal delivery, caffeine, fluid intake, these are risk factors are important. I have included in this in the prevention part, because if you suppose there is para 1 live 1, the patient has delivered and you do some operative intervention and she won't again go for the delivery. So obviously there will be the chances of your failure of the operation. So you recommend any SUI procedure surgery after she completes the family. So you need to see the age, what she is planning family. If she does not want to conceive further, definitely you can go for the operation in that time. Pregnancy and vaginal delivery risk factors, caffeine and fluid intake. Yes, you have to advise certain medication like diuretics, alpha blocker, tricyclic antidepressant. Constipation you need to treat. Chronic cough, a case of COPD, asthma, she's having SUI, you're planning to go for SUI, so you do her basic baseline, you optimize her respiratory symptoms to the better, and then only you will operate, and you will give the best treatment, because obviously there will be some component of, there will always after operation there will be high intra-abdominal pressure, there may be chances of recurrence, so you will give the surgery which has the maximum efficacy or maximum success rate. The conditions affecting mobility, very very important, you need to give the caregiver, if you are to explaining the CIC care, so you should know how the patient is able to do, or the caretaker will give the CIC or anything. Medical conditions, diabetes, connective tissue disorders, stroke, oral estrogen substitution, body mass index, they are on HRT, weight loss, even 5% of weight loss will have drastic improvement in incontinence. And even for the surgery, if you're planning for surgery, you ask patient to motivate initially for weight loss. If after surgery she loses the weight, again there is a chances of failure of your operation. Smoking, diet, depression, UTI, exercise, these are not risk factor for the urgency, but it increases the prevalence and the severity for sure. Conflicting evidence regarding hysterectomy, yes, there are conflicting, means many studies show that after hysterectomy the incidence increases of incontinence, and some show that it does not make any difference. So these are something points to be remembered, and to be consult patient regarding this before you do any conservative or surgical intervention. So prevention, lifestyle changes, whatever the risk factor, you ask her to change behavior, you give them pelvic floor muscle training, bladder training, delayed voiding, timed voiding, prompt voiding, scheduled voiding, electrical stimulation, biofeedback, those who are willing to do the pelvic floor strengthening exercises. There are various vaginal and urethral devices for SUI, neurostimulation, wonderful results, anticholinergic drugs in urge predominant mixed incontinence, as I described one case scenario, local vaginal estrogen in case of atrophic vagina. These are the something prevention you need to do. Do not severely reduce the fluid you drink to avoid going to the bathroom. When the patient, majority of the patient with incontinence, they will reduce their fluid intake. Why? Because whenever they drink the water, they go to the washroom, is like their belief. Or what happens when you reduce the fluid intake, the urine get concentrated and there is more frequency and urgency. So don't severely reduce. A minimum basic amount of fluid intake you have to take. Drink only moderated volumes of fluid. Each time make a habit to go to empty your bladder before going to sleep, but always avoid to empty the bladder just in case. Whenever you're stepping out, the patients whenever step out from the home or their comfortable place, they want to avoid the leakage episode, so they urinate. So that should be avoided and that should be encouraged to the patient. Yes, but before sleep you should always empty. That should be a habit. Always empty your bladder completely. So for that you need to relax your pelvic floor completely and avoid the hovering position. Okay, so reduce caffeine intake, drink bladder friendly fluids, avoid going to bathroom just in case. So this, and reduce your caffeine intake, that is something very important. So what are the good bladder habits? Don't bear down to pee. In females, the it's pelvic floor relaxation is the main by which the urination occurs. So all you have to do is just relax your pelvic floor and do nothing, literally nothing. Drink 1.5 to 2 liters of water daily. Be aware of bladder irritants like chocolate, spicy food, tea, coffee, even the green tea, carbonated drinks, alcohol, smoking. Do not hover over toilet seats. This is the example of hovering. This will lead to the pelvic floor dysfunction. It will not help, and in long term it will damage your pelvic floor. Make sure you sit down and fully relax, and in this avoid taking any electronic gadget, tab, mobile in the washroom, whether it may be for urination or for defecation. Don't avoid too often or wait too long to void. Make sure you void every 3 to 4 hours. This is something very very important. Prolonged time for hold may also give rise to pelvic floor dysfunction. So these are something very good bladder habits which you need to practice. Kegel exercise or the pelvic floor strengthening exercise. Apart from Kegel also there are some exercises which strengthen the pelvic floor. So it helps to restore the muscle tone, strengthen the pubococcygeus, the main muscle, to prevent or reduce the pelvic floor problems. It's the first line management for any type of incontinence, like stress, urge or mix. Basically for the storage symptoms, it has to be done. Again, while said this, in case of voiding symptom, first you confirm that the patient is having voiding or she's having no voiding. When there is no voiding difficulty, then only you will advise the pelvic floor strengthening exercise, or it will worsen. Its benefit greater in younger women because there is good liver and anite tone, and they are able to do it. And with SUI alone, yes, it works more better in the SUI things. Okay, as we said initially also, urgency is something functional. Idiopathic and SUI has the anatomical, just like absence of bladder neck support. So by pelvic floor strengthening, that will also help better in lifting up the pelvic floor muscle, and incontinence will be prevented. So what is the cure rate? It's very vast and it depends. Supervised is better, obviously not the unsupervised one. So it has a cure rate from 28.6 to 80% of the cases you will get the cure rate in patients suffering from urinary incontinence. So, but what it requires a conscious effort to remember daily. Consistency is very important. One day you do the Kegel, next day you will not find the result. Commitment haven't shown to improve. Mild to moderate. In severe surgery, there is no replacement to surgery. Whenever the surgery is indicated, it is indicated. Can be performed anywhere and anytime. Yes, very true. And it has two components: short and long contraction. Improvement of symptoms starts appearing with 6 weeks, 3 to 6 months. Pelvic floor muscle training program should comprise at least 8 contractions performed 3 times per day. So this was how you do the pelvic floor strengthening exercises. Don't lose it. Every day do 10 long pelvic floor squeeze from anus to vagina. Then 10 quick squeezes. Find the right muscle. That's the key. Repeat 3 times a day. Master the neck. That is nothing but the squeeze of pelvic floor before you cough, sneeze or lift any heavy object or lift your baby or laugh. Perfect your technique. Do it repeatedly. You will get perfection with, and maintain your focus because you know to which type of muscle is, which muscles are there. Find the right muscle. So maintain the focus for that. Use a pelvic floor exercise app. There are many apps and reminders so you don't forget and you do it regularly. Deal with constipation. Eat well, sit right, and don't strain. That is something very important. Constipation, root cause of all urogynecology problem. Offer a trial of supervised pelvic floor muscle training for at least 3 months as a duration as a first line treatment to women with stress or mixed urinary incontinence. So pelvic strengthening. So there are various forms which will help you to guide if the patient are motivated and they are able to do it somewhat, or even if they are not able to perform it, then you can have some devices which will help you. That is nothing but the biofeedback. It's a form of alternative medicine which involves the measuring a subject's bodily processes and conveying such information to her in real time in order to raise her awareness and conscious control of the related physiological activity. Biofeedback is nothing, just giving her feedback whether she is doing right now. It can be physical. When you examine, do the pervaginal, you put both finger in vagina. That time also, that is nothing also a biofeedback. You can do a biofeedback by biofeedback instrument as shown here. You can even do the biofeedback by transperineal translabial ultrasound, and visually the patient can see. So there are various programs, software you can teach, or patient can know whether she is doing it correctly and how much, what is the strength and how she need to do. This is something very nice. Allow users to gain control over physical processes previously considered automatic.
Yeah.